The strength of a college is measured by two parameters. One is the numbers of experts or teachers available, and the numbers of patients which it is attracting. For whatever may be the reason, unequitable distribution has occurred. And for various reasons, the Union government wants to support medical education and has given funding to start medical colleges. So for this purpose, for whatever may be the reason, there are some pockets where there are more medical colleges and some pockets which have less medical colleges.
So you have been credited with integrating yoga into clinical applications for mental health. And do you have any plans to incorporate similar holistic approaches into medical education?
The liberty should be given to the doctors from allopathy, which is modern science, to see what they would want to choose from these traditional systems of treatment to integrate into their clinical practice, rather than being exclusive at this point of time.
Right.
Again, evidence has to be built. Evidence-based scientific research has to accumulate. Some has gathered and some is in process of getting together.
Good morning and welcome to South First. I am Chaitanya Belgare in conversation with a very special guest, Dr. B.N. Gangadhar, newly appointed Chairperson for National Medical Commission. First of all, congratulations, sir. So my first question to you is, you have taken charge as Chairperson of NMC when medical education is in an extremely sensitive position. What are some of the challenges that you see here?
We have to strengthen the quality of medical education. That is the primary motive. In fact, sometime down the line, National Medical Commission should become synonymous with quality medical education. That is the objective of the exercise. In fact, that is the purpose with which NMC has been made, to improve the quality of medical education. And that would be my primary focus. What are the challenges? Yes, there are some challenges. I wouldn't say there are too many challenges. One of them is making available the faculty to the students. What are the challenges locally is difficult for me to make a guess. We have simplified the whole processes of making faculty available. From the day one, the entire number of faculty should be available, so that what we may call as competence-based medical education, which is also involving a vertical integration of all subjects which we learn in what we may call as pre-medical, preclinical to clinical. Although this distinction is something that I would really not want to happen. At all time, we are running clinical subjects, but the emphasis in the classes could be different for different years. But a person is learning clinical medicine all through the 5 years of his course. So for that reason, faculty availability at all levels should be very, very important. That I see as an initial challenge. But luckily, colleges have begun to overcome those things. And I'm sure very shortly we'll be able to make this possible. More teachers available, more faculty are coming, which means more experts are there in the hospital. Right from the day one, this college starts getting patients in their hospital. Hospital gets strengthened. The strength of a college is measured by two parameters. One is the numbers of experts or teachers available, and the numbers of patients which it is attracting.
Any other challenges you see, sir? Because of course, hiring of teachers is the biggest challenge, probably the lack of that.
There are, of course, a lot of experts available in the society. There are many other attractions other than teaching could happen once the person is trained into a postgraduate education, the clinical practice, the various laboratories, various industries wanting basic science people to work with them. Those are all truly some of the attractions for which our people, genuinely though, I don't no value judgment on that matter, but we should still go on to produce more and more of those specialists. And those specialists who are not necessarily in a primary teaching job, how much of their time into education, which can be uh, uh, collected from them is another issue that we need to work on. It is going to be a matter which we have to discuss with the educationists, the universities, the colleges, the medical education departments, and then to see how to ensure that all experts are involved in some or other form of teaching, which would perhaps complement to an extent the non-availability of teachers. However, should the teachers also be given better incentive to come and join their colleges into their jobs? Is another issue which I think people are already thinking about.
Yes.
How it will unfold in the days to come, we have to see. But I am confident employing teachers, filling them and ensuring that they are retained is a process that has already begun, and I can see that happening in the last couple of years.
So another biggest concern in medical education now is the number of students, resident doctors dying by suicide, complaining of depression. There are cases of ragging. So, and their allegation is that there is nobody to hear them out. So, what is the
Yeah,
immediate solution that NMC is looking at for
yeah,
that?
yeah. It's true that unfortunate episodes of a medical doctor attempting suicide, for whatever may be the reason, some being completing the suicide, etc., etc. We hear that, and it really pains me a lot that when one of our own colleagues, a doctor, makes this attempt. Now, to say whether these numbers are increasing, I do not have the data actually. The numbers of students have remarkably increased, almost doubled in the last 5-10 years. So the absolute number of the pool of students available is enormous when we say what it was, let's say, 10 years ago. So it might appear that more people are being reported, but it is also have to see the denominator, the student population, which has also increased quite high. But whether proportion-wise, number of people making this attempt per unit of population of the students, has it been increasing? It is difficult to comment. I don't think we have that research data. Nonetheless, whether there is a data or not, increasing or not, even if one such attempt happens, one such event happens, is something that we all have to swing into action, make sure this phenomenon is mitigated. And in fact, anti-ragging or ragging control regulation has been put in place. It's been approved and it is already in place. As part of this anti-ragging, the NMC has already set up a committee which has completed its report already, and it has surveyed as many as about 35,000 students, postgraduates, undergraduates, even teachers for that matter, to see what could be the magnitude of the problem which is there right now in terms of students feeling uncomfortable, students having some suicidal ideation, students having one or other difficulties. This has been already collected. On the basis of that, a national level expert committee was formed by the National Medical Commission, primarily with the interest of the students. Students' welfare is the primary interest that we, at the same time, welfare of all the teachers. So unless the students and the teachers are happy, education cannot become a very, very sustainable agenda. So this is something that we have already focused on. We have already initiated this program. And in fact, a few months back, we already requested all the colleges to put up the information on their stipend that they are paying to interns and residents, to just to bring it to the awareness that they ought to be paying the stipend what they deserve, so that the administrations of the colleges have been told that this will be available in the public domain for people to see. I'm sure more and more colleges will wake up and then put this information, and to be doubly sure that the students are, the welfare of the student are taken care of with respect to monetary support that they are getting during the course, particularly in the post-graduation and in the internship. There are, of course, several recommendations that have been made in this committee report. The National Medical Commission, all the members of the National Medical Commission will soon be having their full copy of that report. In fact, the copy of the report has also been peer reviewed by experts in medical education, both within and outside the country. we have this recommendation in place. How to roll out each of the recommendations, how overwhelming it can become to put in all the regulations in terms of the costs to the college, etc., has to be balanced. We have put 2-3 elements already in place, what we may call as a mentor-mentee program. For each of the student, there is a specified faculty. So in other words, a faculty who is the mentor will take in each batch 6, 8, 10 students into mentoring this person, not just the curricular things, but also several other soft skills and also concerns of the students. So he is something like an immediate local guardian to this individual who will probably follow them up year after year over the next 5 years, let's say, for that matter. This under this mentor, there will be mentees from first year, mentees from second year, mentees from third year, so that there is a mixture of all levels of students with each mentor, which so would be the case with all the mentors. All the students now will be getting a feeling of a sibling-like relationship because all working together under that mentor in those group meetings under that mentor, etc. We are hoping that the senior-junior dichotomy and sometimes amounting to ragging would come down, and they would be some form of a better camaraderie which will emerge over the course of time. This remains to be seen. The mentor-mentee program has, although was prescribed a couple of years ago, has gotten into groove in most of the colleges now. And in the years to come, we are expecting this would make a change in terms of ragging episodes.
Is there anybody monitoring it, sir? Because there are so many guidelines and so many recommendations that has already been done thanks to NMC and several other members of NMC. But is there
all
a
these
monitoring?
ideas, what is important is the colleges have to self-regulate themselves. I believe it is very important that colleges have to rise to the occasion that these are the recommendations and that we have to follow. And it's very important that we give the autonomy to the colleges with advisories and suggestions rather than micromanaging the colleges, which will not be a good idea. And over time, episodes of ragging, etc., if they start coming down, that is a very good monitoring that we already have it. But I think that would be stepping on the feet of the colleges, which are already doing a very good job in terms of education. So this concept of policing every college is not something that is we should be very proud of. So I think the concept of monitoring, regulating, inspecting, policing is something that we should slowly recede and make these colleges learn from each other and, set a very high standards. What should we be monitoring? The quality of training that is happening, the syllabus, the quality of the students, research activities that are happening.
So amongst many allegations against NMC, there is also this allegation that NMC is never transparent. They do not respond to RTI queries. They do not upload data. So there is this allegation. How do you want to respond to that?
Last year, we have already uploaded all the information that is required. The first 2 years, was the preparation that we were doing it. You don't expect on the day you come, you start putting, we really don't know. We are collecting all the information. The regulation that was to be made as to what is the information that we should allow the colleges. What are the information that should be publicly available? What is the third-party information which will really not serve any public interest? This is something that we have debated. We already put in place a regulation, what information that will be put in place. There are patients' data, there are personal data of all the faculty. So these are all the informations which would be very, and then the financial data of the colleges, many things that we collect. What would be public relevant information that I think we need to debate. Over course of time, I think we will evolve something that would be most useful to the public and not necessarily going to be useful. In fact, 2 elements we have already said when the Act says assessments and rating have to be available public. So once we start doing the ratings, the assessments of those ratings will automatically come into the public domain. And more information as we can sieve it out, we're going to be putting it into the public domain.
So, what about doctor safety? I mean, that is something they're constantly working under pressure, not because of the job. I mean, like you said, I mean, medical profession is something which is highly stressful, probably, and they're okay with that. But what about the fear of getting attacked by family members, relatives, sometimes political goons? So, there have been multiple
Yeah,
incidents like
we
this. So,
have to
is
make
there
this
anything you are working towards
It's
on
very
that?
important. This is very important. There are about I don't have the numbers actually. Hospitals run by the medical colleges account for about 1,000 hospitals, whereas I'm sure at least 10 times more or even 20 times more hospitals are there all around in the country. So it's a more, it's not just the concern of only NMC, and I'm sure the medical health service itself is seized with this concern. I'm equally concerned. Many of these issues of violence against the doctors is something that, as a general, unrelated to only the National Medical Commission's agenda, we're all worried about. And I'm sure whatever we suggest, whether it is implementable across other 20 times more numbers of hospitals, is something that the health department would surely look into. We, of course, are educating the students and the doctors about what we may call as attitude, ethics, and communication. Quite often, difficulties and frictions between patients, their family, and the doctor occurs because of some difficulty in reaching the communication to these family members. In fact, the syllabus now has what is called as the attitude, ethics, and communication module that has been put into place, training them and increasing their competence in these communication skills, to be able to approach them with the right attitude and following the ethical guidelines during their clinical work, will all going to make them better doctors other than just being technically sound. So these components, which would not be called as necessarily textbook curriculum components, but I think these are all other skills that they have to be taught, have already been put in place, which hopefully over the time, as and when more and more doctors pick up these skills as part of their education and come out as successful doctors at the end of 5 years or 8 years of training, these skills will actually help mitigating the friction that could happen between the doctor and patients. Currently, yes, there have been happening, and some years back, it was recognized that these skills are going to be very helpful for doctors from navigating out of this such crisis, or even mitigating them or preventing them altogether. So I'm sure this curriculum that has been put into place, ATCOM module, which is going to make a change over course of time. And this is where the NMC comes into place. But preventing action against, taking action against those people who are offending on doctor's activity is another issue which I think right now we will support whatever the health department advises us.
Right. So, while on the one hand, when doctors were pressing for a separate law to protect them, now you have the Bharatiya Nyaya Sanhita bringing them under the ambit of new law. What's your take on that?
Since this is a law, government-related law, as a government servant, I will refrain from making a comment on this. This is something that I think the entire medical fraternity is looking at it. I'm sure there will be some form of action plan they're going to be reporting to the health department. Right now, NMC itself is not an issue into this. I mean, this is not
Yeah,
the
I
primary
agree.
issue of ours is the quality of medical education. And I think I'm surprised that you brought this question up.
No, you're
This
a
might
doctor, sir. You're a doctor, so I think
I'm
I should
here
ask this
speaking as
question.
I am speaking as the chairman
I
of the
agree,
National
sir.
Medical
I agree.
Commission,
But
who is
since you're a
preparing doctors.
doctor,
So at this point of time, personal opinions matter very less.
so my another question was the NEET on NEET. What is your take on NEET, sir?
NEET is an examination which is a excellent way of screening nationally the best students into the examination. Some 24 lakh students
But
have
with
written in.
allegations coming in now
Yeah,
and with the recent,
that is not something that I directly get myself involved. So this is an issue which I think the government is examining this. But NEET is an examination which is very, very helpful to screen at a national level the best students into medical education, UG or PG.
Okay, sir. Okay. So you have been credited with integrating yoga into clinical applications for mental health. And do you have any plans to incorporate similar holistic approaches into medical education?
It's too early to make a statement on this, but there are 3 or 4 things which I think you should take note of. If you go through the regulations, minimum standards requirements, and so on and so forth, there are 2 other things which have already come into place. There is an integrative medicine uh, research unit that has been required to be put in place in most of the colleges, in all the colleges. So the specifics of that perhaps roll out over the course of time, because the way in which they integrate, each college can take a different way of integrating some of the traditional methods into their clinical service. Why is this important? There's some evidence is emerging. For example, since I am working research in the field of yoga, I know applications of yoga in some of the conditions, mental health, I know. I'm sure we have also read in public literature, which is available in public domain, in international journals. There are benefits of yoga into many physical conditions as well. So if there's going to be some benefits from another system of medicine, how to exploit that to the welfare of the patient is something that I think our doctors need to know. Whether they're going to practice it themselves or not is a different issue. If some help is available from another system, how to integrate it into my holistic treatment approaches is something that I think has come to stay. How to unfold it over the course of medical education remains to be seen over the course of time. In principle, this is required. This is my opinion. And also by research, last 25, 30 years, which I have also published. Not just I have published, there are many people who have published. Leading national institutions have already started to have yoga or one of those Ayush systems to be as a part of the collateral services that are already making it available. And research integrating these two has already begun. And many corporate hospitals also are introducing some of these yoga practices into the clinical practice. Some research is already coming from these hospitals as well. So put together, it's important that we should not be exclusive in our approaches, and how inclusive we should be in the benefit of the patients is something that will evolve over the course of time. Encouraging this perhaps is required. So apart from making this integrative research unit as part of a medical college, we have also suggested to the students there's an elective clinical posting that they can avail in their internship. And if there is an opportunity in the college, it is not mandated again. This service of one of the yoga services or whatever it is, if they want to get themselves exposed to that, this freedom should be available, although it is not mandated. So this is a elective posting. They will go for a week or 10 days, and this opportunity should be there. It's a question of time, and it's over time. The liberty should be given to the doctors from allopathy, which is the modern science, to see what they would want to choose from these traditional systems of treatment to integrate into their clinical practice, rather than being exclusive at this point of time.
Right, right.
Again, evidence has to be built. Evidence-based scientific research has to accumulate. Some has gathered, and some is in the process of getting together. So any approach of integration cannot be done without sufficient evidence base that we are going to be generating. And
Right.
this research work is the reason why this integrative research unit we have mandated in all the colleges. Evidence has to be built, and people have to actually hands-on experience the benefits of this integration, both experience and also the evidence in clinical research. Put together, integration would potentially happen, and time only tell us how well it will unfold in the days to come.
Right, right. So, any one last message which you want to give, sir?
Yeah, I recall sometime back this discussion had happened why there has to be a population-based limitations of the medical seats available and so on and so forth. Why is it unequitably distributed? For whatever may be the reason, unequitable distribution has occurred. And for various reasons, the Union government wants to support medical education and has given funding to start medical colleges. So for this purpose, the for whatever may be the reason, there are some pockets where there are more medical colleges and some pockets which have less
Right.
medical college. Overcrowding of the medical colleges has had some concerns. In fact, one of the honorable high courts has made an observation in the verdict that it has passed. So why overcrowding should not happen? Hospital of the medical college is a service unit, and if tens of hospitals are crowded together in a small area of a population, which again serves very little purpose for that population. Then there's already one hospital, and you have another 2, 3, 4, 5.
Right.
By
Right.
adding more hospitals in a smaller area, the number of patients coming to each hospital has to be finite anyway. It's not going to increase, and this resource gets impoverished to the students getting admitted into this. At the same time, places where there are no hospitals continue to have very poor supply of medical services. So it is desirable that the colleges are distributed evenly so that the services reach out to the patients. At the same time, the students who come in are going to have to travel all the way to only one state or one pocket of the district to learn their clinical material. And evenly distributed will attract more patients to each of the hospitals. So, for these discussions that have happened in the light of this court's observation as well, we took a decision that 100 seats per million population would ensure we having an opportunity to add another perhaps 40 or 50,000 seats to the country if it is evenly distributed. With that spirit, we propose that, not so much to curb medical colleges in some areas.
But that,
which could-
but this policy would actually mean that, so South India may not really get as many medical colleges it needs. So how do you address
That
that?
is a very skewed observation that some could have had, but it's also true that it will encourage more North Indian colleges to come up. Why don't you see the other part? Why don't you see the cup is half full rather than saying cup is half empty?
So we don't
So
mind
this is
not having more medical colleges, but then the ones which exist also do not have infrastructure. So there is no monitoring happening there. So
yeah, that's the point. So there's all the more reason why colleges should not come up. You are having the answer in your own question. More colleges means less infrastructure. So that's precisely the reason what we are saying. If there's 100 per million population, even the resources of the available specialist teachers will also be evenly distributed. So with this keeping in mind, we have no objection to very good colleges coming up. But you also have to see the population which is serving that purpose, providing the clinical material to the colleges. Why everybody should travel to only one district to get the medical service? Why he or she does not have the right to get this treatment from this hospital nearby to his house? So impoverished districts with respect to medical college should be encouraged. This is the objective with which we put it, but the way it has been read is totally different.
Okay, sir. Okay, sir. So thank you very much. It was really wonderful having you, and I'm sure that under your leadership, it is going. We are hoping that a lot of things will change. The perception about NMC will change.
The last statement is I have to state that medical education by all the colleges is something that is a great input that we have received. More medical colleges are doing a wonderful job, but whatever challenges that they have, whether it is the availability of teachers, availability of patients, or availability of resources financially, but for their contribution, more and more doctors would perhaps not be available. Our business is to ensure that the doctor who is coming out has the best competence. And I'm sure with all your support, all the medical colleges support, we will endeavor to achieve this. Thank you so much.
Thank you very much, sir. It was wonderful speaking to you. Thank you, sir.